Welcome to the deep dive. Today, we're really digging into a critical piece of healthcare economics.
That's right. It's all about costs of illness and cost-effectiveness analysis.
Exactly, how we actually measure the full economic hit of different health interventions. And getting it right, well, it's vital.
Because these numbers, they really can sway major healthcare decisions.
Totally. So our mission today is to unpack three, let's say, tricky methodological areas that often cause problems in these analyses.
Things that can lower the technical quality.
Yeah. First, telling the difference between incidence and prevalence costs. Second, whether to include those indirect costs.
Like lost work time.
Right. And third, how to handle medical costs for other stuff that pops up when an intervention helps someone live longer.
The unrelated costs in added years, it gets complex.
It really does. Okay, well, let's get into it. So this cost of illness, or COI, fundamentally, how do we start measuring it?
Well, at its core, there are really two main approaches. You've got prevalence-based costs. Think of that like a snapshot.
Okay, a snapshot.
Yeah, it measures the economic burden happening right now or, during a specific period, like a year.
Gotcha. And the other way?
That's incidence-based. It's more like looking at the whole lifetime cost.
Ah, right.
From the moment someone gets a disease until they're cured, or, well, until death.
So lifetime versus a specific period, which one's correct?
Well, that's the thing. It depends. It depends on the disease, chronic versus acute, and what intervention you're actually analyzing.
Makes sense.
And here's a crucial point for any analysis looking forward, especially those incidence-based ones. You have to think about future technology changes.
Oh, interesting. Why is that so critical?
Because if you're estimating costs over decades, like for diabetes or heart disease, and you just assume today's treatments and costs stay the same?
You're going to be wrong.
Exactly. You'll likely underestimate future medical costs, potentially by a lot, which introduces a serious bias.
Yeah, you gave that example of coronary heart disease in the U.S., back in the late 80s, early 90s?
That's a classic case. You saw huge jumps in procedures. Catheterizations up 6% a year, bypasses 9%, obstruction removals a massive 25% annually.
Wow.
If your model back then ignored those trends, it would make interventions look way less valuable than they turned out to be long-term.
So the lesson there is you need flexibility in the models.
You absolutely need it. Running sensitivity analyses, basically, testing different assumptions about future costs and tech is vital. It helps gauge the real long-term value.
Okay, so the when and the what might happen later are huge. What about the what we count right now? Let's talk about indirect costs.
Right, so this isn't about the hospital bills or drug costs. This is the value of, say, productive time lost because someone is sick or dies prematurely.
So lost wages, salaries, even unpaid work like household chores.
Exactly, and these are not small potatoes. Often indirect costs can actually be higher than the direct medical costs.
Really? Higher?
Oh, yeah. There were studies on diabetic retinopathy, for instance. The cost per year of good vision gained. It doubled when they left out indirect costs.
Doubled. Wow.
And for hepatitis B vaccination, the cost per QALI, that's a quality-adjusted life year, was up to 18 times higher if you ignored lost productivity.
18 times. Okay, so why wouldn't you include them then? Seems obvious they should be in.
Well, that's where the debate really heats up. There's a school of thought, often called a pure CEA, or cost-effectiveness analysis. They often exclude these indirect costs. Sometimes it's ethical concerns like, does it unfairly favor treatments for working-age people over kids or the elderly?
I can see that argument.
Or sometimes it's about keeping the analysis strictly focused on health outcomes versus broader economic benefits, trying to avoid blurring lines with cost-benefit analysis.
Okay, but there's another view.
Yes, what's often called modified CEA. This view basically says, look, enhanced productivity is a real economic consequence, a benefit, and we should count it when it's relevant.
So it depends on the perspective you're taking, like society's perspective versus maybe just the healthcare systems.
Precisely. It depends on perspective, what you're measuring effectiveness against, and crucially, who actually bears those costs. It's a fundamental split.
Okay, complex stuff. Now let's tackle the third point. An intervention works, someone lives longer. Great news.
The best outcome.
But in those extra years, they might develop, say, heart disease or cancer completely unrelated to what they were treated for originally. What about those medical costs?
These are the unrelated downstream costs.
Yeah.
And yeah, it's another contentious area.
So include or exclude?
Well, many argue you should include them, at least in that modified CEA framework.
Why?
The argument is These costs are an unavoidable economic consequence of the intervention succeeding. Unlike buying a new TV, you don't really choose to consume medical care when you get sick in old age.
Right. It's often necessary.
And it's often funded collectively through insurance or taxes. So excluding those costs kind of understates the true, full economic impact of extending life from society's point of view.
Okay, that makes a certain kind of logical sense, but does that mean we should start adding everything people spend money on in those extra years, like food and housing?
No.
Yeah.
And the paper we looked at is clear on this distinction. It argues you should include the unrelated medical costs, but not general consumption like food, rent, whatever,
Why not? If they're alive, they consume things.
because that starts getting into weird territory based on tax policies, savings rates.
Mm.
It messes with basic economic ideas like the circular flow of income.
Okay, so it muddies the waters too much. Stick to the medical side of things.
Essentially, yes. Keep the focus on the health and healthcare cost consequences, both related and unrelated downstream medical ones.
So wrapping this all up, these aren't just minor academic quibbles, are they?
Not at all. These distinctions, incidence versus prevalence, indirect costs, downstream costs, they profoundly shape how we judge health interventions.
And ultimately, how healthcare gets funded.
Absolutely. The fact that there's still disagreement, especially on indirect and downstream costs, really shows why we need clearer standards.
More consensus among researchers and policymakers.
Exactly. That would make these analyses much more comparable, more credible.
So for you listening, understanding these sort of hidden layers is really key to seeing the full picture behind health policy decisions.
It really does affect everyone.
Definitely makes you think about what cost and value truly mean in healthcare, doesn't it?